My name is Taneeka Stephens, and will be presenting about National Patient Safety Goal for reducing the risk of healthcare-associated infections. Quality of care and patient safety are core values of the Joint Commission, and is also a commitment to patients, family, as well as ourselves as healthcare providers. An estimated 98,000 patients die each year as a result of errors in the U.S. healthcare system. The first obligation of healthcare is to do no harm. The patient safety systems focuses on 3 guidelines, and those are implementing Joint Commission standards in order to engage patients and staff in reducing harm in all circumstances, assisting healthcare organizations with advancing knowledge, skills, and competence of staff and patients by recommending methods that improve quality and safety processes, and encouraging proactive quality and patient safety methods that increase accountability, trust, and knowledge. When we're considering our goal to keep patients safe, we must consider providing quality care. The definition of quality is the degree to which its processes and results meet or exceed the needs and desires of the people it serves. I wasn't ready yet. Okay. And then patient safety is defined by the World Health Organization as the prevention of errors and adverse effects to patients that are associated with health care. Healthcare-associated infection is a patient safety event as it is an incident that could possibly result in or did result in harm to a patient. So reducing the risk of healthcare-associated infections, I included 2 diagrams here that talks about the statistics and probability of patients acquiring healthcare-associated infections. The Joint Commission of 2018 came up with these standards for reducing the risk of healthcare-associated infections, and they include complying with either the current CDC or WHO hand hygiene guidelines, implementing evidence-based practice to prevent healthcare-associated infections due to multi-drug resistant organisms, central line bloodstream infections, surgical site infections, as well as CAUTIs. According to the Center for Disease Control and Prevention, each year, millions of people acquire an infection while receiving care, treatment, and services in a healthcare organization. One of the most important ways to address the spread of infection is through proper hand washing of healthcare staff. Compliance with the World Health Organization, or CDC's hand hygiene guidelines, reduce the transmission of infectious agents by staff to patients, thereby reducing the incidence of healthcare-acquired infections. So on this slide, I just have the CDC recommendations as well as the WHO hand hygiene recommendations. And then this picture shows the proper technique for washing your hands. This is the evidence gathered from an article that focuses on the effect of hand hygiene in reducing healthcare-associated infections. This is a chart of the results of a study that was done to distinguish the impact that it has on acquiring infections. The association between hand hygiene compliance and healthcare-associated infections, adjusting for unit-level data, showed a 10% improvement in hand hygiene associated with a 6% reduction of acquiring a healthcare infection. This intervention in reducing healthcare-acquired infections is focused on targeting multi-drug resistant organisms. These organisms include MRSA, C. diff, VRE, and other gram-negative bacteria. Educating staff on prevention strategies consistent with their roles within the organization help to minimize the spread of these organisms. In addition to the education of staff, patients and families also need to be educated. Implementing practices supported by evidence-based standards and guidelines is necessary in promoting care that reduces the spread of organisms, thereby reducing the acquisition of healthcare-associated infections. When talking about bloodstream infections, some of the same guidelines are put into place, and that includes educating staff, patients, and families performing hand hygiene prior to insertion and maintenance or manipulation, using sterile barrier precautions during CVC insertion, using standardized protocols for disinfecting catheter hubs and injection ports before accessing ports, evaluating CVCs routinely and removing non-essential catheters, use of alcoholic chlorhexidine antiseptic for skin preparation during CVC insertion unless contraindicated. In reference to surgical site infections, the guidelines that are put into place are educating patients and their families as needed who are undergoing a surgical procedure about surgical site infection prevention, measuring surgical site infection rates for the first 30 or 90 days following surgical procedures based on National Healthcare Safety Network procedural codes, and then also administering antimicrobial agents for prophylaxis for a particular procedure or disease according to methods cited in scientific literature or endorsed by professional organizations. And then this last slide talks about CODIs, and it says no CODIs. It uses an acronym to discuss some of the guidelines that we should be using in preventing healthcare-associated infections. The N stands for need. You would like to assess the need for the catheter. And then the O for obtain, make sure the patient has consented to receiving the catheter. Competency is just making sure that clinicians who are inserting the catheters have documented competency. Asepsis, maintain asepsis during insertion and while catheter is in place. Unobstructed flow, make sure there are no kinks or loops, that the catheter is secure, that the bag is below the bladder level and off the floor. Timely catheter is making sure we remove the catheter as soon as possible. And infection risk, collect urine specimen only when clinically indicated. Educating staff and the licensed independent practitioners involved in the use of indwelling urinary catheters about CODI and the importance of infection prevention. Education occurs upon hiring or granting of initial privileges and when involvement in indwelling catheter care is added to an individual's job responsibilities. Ongoing education is necessary. Next slide. And so this is an article that I found on the reduction program for CODIs. These are diagrams from a research article that focuses on reducing CODIs in the hospital setting. The CODI reduction process shown on the left was established by a leadership team, including nurses amongst other staff. This interdisciplinary CODI task force developed guidelines and processes to reduce CODI in the ICU setting. Processes included education, increased rounding on patients with catheters, monthly evaluation of every CODI case, as well as a CODI algorithm, which is seen here on this slide as well. The CODI acronym focuses on identifying if the patient has a cause or indication for the indwelling catheter prior to insertion, as well as determining the need with rounds, which is determining opportunity for removal of the catheter. Assessing the necessity for the catheter is essential, as sometimes alternative methods can be used and or patient's conditions changes and the patient no longer needs the catheter in place. Utilizing infection prevention measures such as proper technique and sterility is required. Teaching the patients and family of maintenance of the catheters, risk for infections and prevention, as well as signs and symptoms of infection is also very important. Informatics and data collection is significant as well. In this study, with the importance of these processes, CODI incidence was reduced as shown in the diagram on the right. Data was collected over a 12-month period, demonstrating a decline in infection ratio by 32%, and then performed again in 18 months, illustrating a 73% reduction. This process for CODI reduction has proven successful in the hospital's intensive care unit and can also be transferable to any medical surgical unit as well as any specialty units. With all of these interventions being put into place and guidelines, we have improved patient quality outcomes. So on this, I have pictures that show how hospital-acquired infections negatively impact our patients, as well as the cost of facilities and organizations in which these incidences occur. The diagram on the right came from the study we previously discussed with the CAUTIs, and it shows a decrease in CAUTI incidence, which is quite significant, as well as the reduction in cost. With reducing the incidence of hospital-acquired infections, we benefit our patients, our staff, as well as healthcare organizations altogether. Safe, effective care is provided with the use of interventions proposed in this presentation. We must keep our patients safe and provide the best quality of care through evidence-based practice. As we mentioned in one of the first slides, we have an obligation as healthcare providers to do no harm to our patients. And that concludes my presentation.